Jake Krilovich, and he is the executive director of the Home Care Alliance of Massachusetts, and it's a trade organization with over 180 home care, home health, and hospice agencies in our state. He joined the Alliance in 2017 as director of legislative and public affairs. And then in January 2022, he succeeded Pat Kelleher, who retired from the Alliance. So she or he, I feel embarrassed, Jake, because of COVID, that I can't remember if Pat's a she or he, but I know the name well, and led the organization for 26 years. So, and what a time, you came in, during a really unbelievable time, right? Not only in home care, but in other areas, as we've been talking about over the COVID period and post-COVID period. We are also going to have Isaac Siegel with us, who's from Petty Pals of Notre Dame Healthcare, and he's got a MSW and an LISW and an MBA. So he's clearly, their program is an example of a service, right? With Chaz Nursing as part of it, but they do palliative care and they do hospice care. And then there'll be a few parents, Jake, that you may recognize that come on as well. But we really want to just to tell everybody who's new, for those of you that are new, what's really important about this is every recording we do, especially these recordings, because there's going to be several weeks we've had of crisis, the crisis that individuals and families are facing. These will be promoted as a group of recordings as well. So just want everybody to know that and how important that's going to be. So, and just want to ask all the Angelos checking in to just update their names, and when you get a chance, so we can introduce you also with Jake and Isaac's help. So first, Jake, why don't you sort of set, I know some people just came on, but I'm going to let you set the table. And I think, Isaac, I already introduced you. I think you just came on my screen. I feel like you're right below Jake, but that doesn't mean everybody else sees that. When you get a chance, just rename yourself as well. But Jake, why don't you just start with outlining it, and then what I'll do is I might ask you a couple questions, and then I will go to Isaac and ask about sort of the experience he's having. And I know we have one or two parents with us today too that do get services, the continuous nursing services. And Amy, are you one of those parents? Just to check in with you.
Yes.
Okay, great. So we'll be, as everybody knows, we've been talking a lot about in-home supports and the lack of staff and the day programs. And this is another key area that's real concern to the ARC and to others. So Jake, let's start, and maybe you could paint the landscape a little bit.
Sure. Yeah. No, thank you thanks for having me today. This program called the Continuous Skilled Nursing Program, I think when a lot of people think of home health or home care, you think of the traditional VNA services, post-acute surgical recovery or rehab services. But this program is a fairly unique, small but mighty program that was, I believe, created maybe in the late 90s, but many years ago, where the state of Massachusetts really committed to the idea that children with medically complex healthcare needs deserve the right to age with their families at home and not in a facility. And really, the state committed that was their right. They would receive skilled nursing services in the home. And so we have, there's probably about 20 to 30 home health agencies throughout the state that provide these services to about 900 medically complex children and some adults who age into adulthood that still require the services. And these are very acute, highly complex patients. And so the nursing workforce challenges are even more unique than they are for traditional home health services, much having to do with reimbursement rates and whatnot. But I can pause there.
Leo, you're muted.
Yeah, I saw it. Yeah, thanks. I just want to say, and that historically, just so in that it might have even been before the late 90s, because I know we did an advocate full page on the crisis soon after I came to the ARC in the early 90s. And I think it originally started related to Katie Beckett, the federal Katie Beckett waiver. And in our state, it was called, of course, I'm going to space out. Carrie, do you remember what it was called? In our state, it's TEFRA, is the federal term for the program.
Kaylee Mulligan.
Kaylee Mulligan, thank you. So that might have been, so you're right in the sense that probably a new program evolved out of Kaylee Mulligan. But you know, it was an unbelievable period back then too, with the reimbursement issue. And just in terms of your membership, you know, your membership's very broad, right? So how many can you tell me without you putting you on the spot? Like there's 900 in this program, 900 and like you said, mighty, because it's a significant support to the 900 who need the sport in their daily lives. How many thousands are probably served through home health, you know, through your alliance? Just in terms of your
I think, you know, in terms of Medicare home health, it's probably over 100,000 Medicare beneficiaries who use home health services annually. You know, there are probably about 60,000 older adults in the EOEA home care program. And then there's the Medicaid home health, excluding this CSN program. So, yeah, you could consider it probably a drop in the bucket compared to the amount of home health services that
I know in the 90s, and I'm assuming again today, and it's always, by the way, it's always an uphill fight. So let me not, you know, try to say it was great for in 2001 and 2002, but because it's a subgroup, right? And it's sometimes in the thrust of the advocacy and the thrust of legislators' awareness, right? And administration awareness. It's easy to try to sort of patchwork a solution for this important program, right? So, and I just wanted people to know that, and Medicare is obviously better reimburser than Medicaid, and this program is all Medicaid. Okay, so again, our Mass Health is what Medicaid is in our state. So Isaac, do you want to talk a little bit about, you're at Notre Dame Healthcare, and I introduced you earlier without you being here, but you have a LICSW, which means you have a Master's of Social Work, fellow, you know, background there with me, and but you also have an MBA, and you are on Petty Pals out of Notre Dame Healthcare, which is, I was saying, was both related to palliative care, right, and hospice care. But do you want to share a little bit of what you're facing in the CSN program and some of the challenges you have, as I assume, as a provider and someone who's very concerned about reaching your families?
Yeah, thanks very much. Yeah, I am a social worker in the PD Pals program. For anybody, I don't know most of you, so PD Pals is a Department of Public Health program that provides palliative care services for families in the community who are taking care of kids with life-limiting illnesses. And what we do in our program is we have services like consulting nursing, social work, child life specialists, and we have music therapists, massage therapists, and spiritual counseling. So we do provide that kind of wraparound. My experience with the continuous skilled nursing, my friend and I guess client Amy and colleague, in so many different ways we're connected. We are both working on improving the access to continuous skilled nursing by reaching out to legislators, elected officials, and other stakeholders in the community to try to give parents a voice directly with people who can help to influence budgets, legislation, preparatory programs and the like, to improve access, to improve the availability of a workforce, to improve funding, and whatever other factors will make the life of the parents more bearable by improving home nursing.
Isaac, and I'm going to have Amy jump in as well soon, but can I ask you, can you give people a sense of, in terms of your, you and Amy, in terms of the people you support, what do you think the hours lag is? Take a guess.
Well, the reports that we've seen show that about 62% of the overall nursing for the population, the pediatric population, 62% of the hours allocated have been filled. Okay, so that means that, you know, if somebody has 100 hours, they're only getting 60 hours. The bigger likelihood is that there's a whole bunch of people that aren't getting any in certain parts of the state, and other people have 100%. So it's really very uneven. What we're finding in terms of the population is people who have had nursing for a long time have a stable workforce, you know, where they have backups and all that. Other people who've come on in the you know, the last few years are having a really difficult time. You know, we find that it also extends out beyond home nursing into education, which is something that, you know, is really risky. A lot of parents have kids who have seizures that go on transportation, and there's a real problem with getting nurses, RNs, to go on transportation for an hour or two each way. And, you know, just picking up people for shifts like that is incredibly difficult. And then getting monitors or even LPNs to be able to administer rescue meds in this state is a real crisis. So parents are basically doing a crapshoot, putting their kids on a van, sending them to school and wondering. So, you know, it's really
Yeah.
a mess.
I thought on education, you were also going to say there's issues at the schools with getting nurses as well.
Yes.
I do think having shorter routes makes a lot of sense, by the way, in that regard, right? The route situation, which I know we're not going to solve this week or this
Yeah.
year, but it seems to like talk about risk. It's just not only is it ridiculous, you know, to have someone in for that long a commute, it just adds to the risk, as you said, you know, so.
Yeah, just to the roots, just for a minute, that, you know, it's the facilities being available in the communities, and, you know, sometimes there's, you know, we can't solve that. There's an economy of scale.
No, that's a whole, right. Well, I'm hoping we can solve that over time, but you're right. It's also related to money, honestly,
Yeah.
right? And
Yeah.
it's just one other thing. And we have a task force that has its last meeting tomorrow on one type of transportation, human services transportation, and PT1s for people going to medical appointments. But it's a bigger issue, much bigger issue, when you have 351 citizen towns, right? That also deal with that. Amy, do you want to share a little bit about what you're seeing, and whether it's in your life and or others that you know, and would love to have you. And you know what, folks, I just want to say something. I didn't say this at the beginning because at first people came on slowly. They were part of the team here. And some of you were expecting a good friend and colleague, Angela Ortiz, and a close friend of hers had a death in the family. So she's at the funeral today. So just to fill you all in, and the people that'll be watching this recording. I'm so pleased that Jake, Isaac, and Amy, who, you know, some of you who were going to be joining us anyway are able to join us, and we're able to stay focused on this so important topic. Amy, so please jump in.
Yeah, thanks for having me. Yeah, so my name's Amy Jozan. I have a PhD in forensic psychology. I work in mental health as an intensive care coordinator. I'm also back in school to work towards getting my LCSW, or MSW, and then LCSW. And I, most importantly, have two beautiful children, one of whom does utilize CSN services, as well as a slew of other services. That's how I got connected with Isaac. My son has quadriplegic cerebral palsy and requires assistance with, well, virtually everything. Using the restroom, he's incontinent, sometimes he needs to be cathed. He requires BiPAP, he requires intranasal suctioning, he requires ongoing support with seizures. He has, I think it's retractable epilepsy. So we are pretty much on high alert around the clock. His seizures don't actually set off his alarm or change his vitals at times. So he can start clustering, and we wouldn't even know it until it is an actual emergency where he might actually need a ambu bag or other supports. But I am also in a military family. So a little bit about that. We've moved around. So we've seen services from different areas, which has been very interesting and enriching. And a little bit about that, I moved from Atlanta, then to North Carolina, then to here. Well, the reason why we fought so hard to be here is because we wanted access to services. We thought that that would increase my son's quality of life, meaning that we would be able to also have an increased quality of life. I could work and support my household. And that was the dream. So when we moved here, we went from having 84 hours of continued skilled nursing back in North Carolina to having 49 hours here. They completely drastically reduced our services. And as a result of that, my son had 6 hospitalizations after going 2.5 years without a hospitalization, and then an additional ER visit in less than 6 months. One of those times he was
How
actually,
old's your son, Amy? How old's your son?
he's 9 years old. Yeah.
Nine?
Mm-hmm.
And you're saying basically, and I hate to, you're doing a great job, and I hate to do this, but I love, like, just dig deeper on that.
Yeah.
You're basically saying you had approved in North Carolina close to 90 hours. You
Mhm.
came here, it's not even finding the nursing. You just didn't even get approval for the same ballpark.
Right.
Wow.
And it took 3 agencies to fill 49 hours, and there was high turnover. It was drastically different than what I had experienced in other states. Of course, I had only experienced, Atlanta and North Carolina, so that was completely different. But yeah, 3 different agencies, and the way that they allotted and assessed for hours is completely hands-on. So when you think about only 62% of people's allotted hours being filled, which hasn't been a reduction really as a subsequent from COVID, because really only 67% were filled previously. Yeah, when you think about how those services that are medically necessary and based on minute to minute hands-on care, these children are at extreme risk for being pulled from their communities. Not only that, but where are they going to go? There is nowhere for these children to go. So it's almost I don't want to say slavery, but it is forced labor, and there's not a lot of help. We are looking for
indentured servitude,
servitude,
which
right?
is what a former secretary was would call it, that we're trying to get away from that, right? And
Right.
but so I'm shocked. I have to be honest, like that, your hours, even on paper, reduced. But this is interesting because we have the same problem as with the PCA program. Are the families offered a combination of nursing and PCA? And it's the same issue there. It's minute by minute, right? That you get approved. Physical prompting, physical assistance, not prompting, physical assistance for those things. Do you happen to have any of those hours for your son?
So we do, and they do not offer a whole lot of those hours because at this point, my kids' healthcare got so much more intense and overwhelming that now we are up to 110 hours per week, which could have been avoided, I believe, if we had the right services to begin with. But with PCA services, they don't let you bill for having a PCA and a nurse together. So if I'm lifting my kid who almost weighs as much as I do when I'm home, also, if the nurse is by themselves, they could be at risk for hurting themselves, and you have to have enough room to have a Hoyer lift and to be able to accommodate all of these things. And that takes money. It does. So a lot of us do wish to work, but we're not afforded that opportunity.
You said your son, just to remind people, because I'd broken into your narrative. How many times was your son in the hospital, and then how long a period had he not been again, just to remind people?
So yeah, when we were in North Carolina, we went 2.5 years without a hospitalization, and we had our hours filled, all 84 of them. And he was a lot more basic to care for. He would get respiratory viruses that made him very difficult, and he was around the clock. But other than that, he was a lot more stable. And then we moved here, got 49 hours. And that wound us up with a lot more intensive care needs because he did decompensate. And what that did to my family, we still feel the effects of it today. We're now up to 110 hours and really struggling to fill those hours so that we can work and continue caring for both my children, not just Parker.
Right, right. When you transitioned here, do you think the handoff, like that the state assumed certain things based on how well he looked because of what you had in North Carolina? How much of that is, or is it, you think that had no bearing on it? That people, in other words, would it have been helpful for the state to have looked into historically? Did they even try to look historically on why he got so many hours in North Carolina?
So in North Carolina, basically the physicians provided the recommendations as to why children needed the services. Here, they don't look at assessment needs. So that's like a huge problem. The physicians have really no grounding in how much a child really requires, and which is medically necessary to keep them safe in home. It's a desk nurse who's looking at hands-on care. And by hands-on care, I'm saying if a child is on a continuous need for pulse oximetry, so you can see what's going on with their heart rate, the nurse says, I'm only going to give 3 minutes per hour for them to respond to alarms, because the pulse ox is doing the job of what the nurse would typically be doing.
And that's, and you're saying no, because you need someone there in case things aren't going well. 3 minutes is just not enough for the
3 minutes
situation. Just to
per
describe
hour.
to the people, to
Right.
those of us that are, greenhorns at this.
Right. And to make things so very clear too, just off of personal experience, my son was having up to 80 seizures per day. They gave me 3 minutes of nursing care a day for that. The reason for that is because he wasn't needing oxygen support. But they gave me 3 minutes to give him medication to stop the seizures. That is it. 3 minutes a day.
Wow. Yeah. Isaac and Jake, is this pretty common, sort of the under, using a more generic assessment tool and giving lower hours than, do you find this a lot?
Absolutely. Absolutely. We have another person who's working with us who came from Maryland, and her daughter has intractable seizures and nonverbal, and was stable in Maryland with 109 hours of nursing, and came here and was allocated 35 hours of nursing. The mom herself works in the medical field and could not survive. She's a single mom, and actually had to put her child into a facility. But before that child could go into the facility, a feeding regimen that she'd been stable on for 4 years had to be changed, because rather than having a one-to-one nurse to manage her feeding, they have a 14 patient to 1 ratio in the facility, and they couldn't manage the type of feeding that she needed. So the child had to be in the hospital for an additional 6 or 8 weeks before being transferred to the facility to move off a stable feeding regimen and onto a completely different protocol. And so far what we've been tracking in terms of cost is that because the state had decided not to provide more than 35 hours of nursing, that there's been at least $500,000 of additional cost to the state for all of the changes that have happened. And that's not including the additional cost to the private insurance that this person has.
This is in that just one case.
Yeah, just one case.
So, love to get both Amy's story, the fact that they came from different states and the experience they had. We'd love to, if you have, that kind of write up, and you could fill us in, we could talk offline about the people you've talked to in the administration. Obviously, there's a change in administration that's going to be going on. We're in that sort of gray zone period, but advocacy still continues during this gray zone.
One of the areas, because we've also had the opportunity early on to talk with Diana DiZoglio, and in her new role, so she's really familiar with us. One of the things that we're going to ask her to do is to audit the validity of the, way that CCM determines and allocates how many nursing hours.
Gotcha. Good, great. And just for people, that's the new state auditor that got elected November 8th, I think. Voting, I guess at night, whenever the top results came in, that was declared the winner of that election. Jake, when you guys talk to, are there different groups within the alliance that sort of negotiate around continuous nursing with the administration? Because I assume this program falls under the Office of Long-Term Supports and Services, or no? Yes?
It does. Yep.
Yeah. And
Under
there's
Mass
been turnover. There's been turnover in that office. And when the hours piece is brought up with them, I assume you talked to Whitney Moyer one time when she was still there about this, right? What would be their argument, Jake and Isaac, for this, the way the assessments have worked out?
Yeah, the assessment tool and authorizations has always been a pretty opaque sort of process, and it's encouraging to hear some of the ideas that Isaac has around the auditing. We've always sort of pride on getting better access to the tool so that families could see it. There have been situations from time to time where families feel like they are being authorized for less hours. And then there are times when the home health agencies will back that up and feel like the agencies themselves are feeling that as well, in terms of seeing patients being discharged out of a hospital with similar, a similar setup that they would need, and seeing a smaller authorization. But again, without the real transparency around the assessment tool, it's been difficult. I think that Mass Health feels like the assessment tool is, I don't want to say black and white, but I think that they feel that the CCM case managers follow it, and as it's written, and that, it sort of authorizes what is inputted. But again, without seeing it, it's always been difficult to, track it.
So I know in the case of AFC, for those of you, adult foster care or adult family care, the trades, we were able to see as an advocacy organization some data that the trades had paid an organization to do for those agencies, right? And what we found, there was a minority that were able to make money in that program that was significant, but it was also based on lower care management ratios. It was based on really statistics that did not reflect the broader. In fact, if you took them out of the numbers, what you found is organizations that barely broke even or showed deficits running that program. And I wonder how much, the fact that there's only 900 people served, right? And how much juice there can be around things like that. But it sounds like we need an overall Office of Long-Term Supports and Services strategy with these different programs. And the most recent thing I've heard, in that, again, a related program, Rehabilitation, the Department of Developmental Services has been giving extra money for one-on-one for people in that program that's transitioning to Mass Health. And I've heard from colleagues already that people that have gotten significant one-on-one are going to get less one-on-one based on the Mass Health tool, even though that won't go in effect for a year and a half. So that reminds me of what Amy went through, and the person you mentioned, Isaac from Maryland, about the lower hours when they first arrived. And so there might be something endemic there across the board at OLTSS that's got to be looked at. And for those of you that are listening that may not know that, the Office of Long-Term Supports and Services oversees range of programs that are not necessarily healthcare or hospital-based, right? That are necessary for people with disabilities or seniors with disabilities to live in the community. And I guess it also, I might cover nursing homes as well, and PDs, pediatric homes. Anybody want to ask some questions? I mean, we could, the cases that you just shared, I think The auditor won't get in place till January, so we're talking about something probably a few months off, right, at best, maybe March or April. And I don't know if the experiences, Isaac, that you've seen with Amy, with the other person from Maryland, if that's helped you and the other families in advocating for the hours. Has there been a change in behavior or not?
Not so far, we can't detect anything, because
Nothing macro.
we're a group. Yeah. We're at the micro level and advocating still.
And when well, let me not get into the rubrics. We can talk offline about the people you talk to and their, I'm going to sound very ignorant when I say to you, I'm really shocked about the hours piece, because now it reflects what people go through for the PCA program. And yet nursing seems to me much more significant, right, for people to need because of the medical implications. So I'm shocked that they would, and to me, it's like applying the same behavior that has been applied for years in the personal care attendant program to the continuous nursing, what I used to call block nursing,
Yeah.
And that's wow. Okay, obviously it's been going on for a while, and I on the recruitment piece pre-COVID, and I was visiting a CAB, Consumer Advisory Board in Northeast Mass, and a person said she had 90 something hours approved, of which she could fill 17. So your answer, Isaac, about what people are experiencing being all over the place rings true to me from that experience too. She was nowhere near 60%.
Yeah.
Anybody want to ask some questions or add their, if you're new and you also are part of this, and care about CSN and want us to be more educated about it. It's just for our community, there's such a range of important services, right? Go ahead, please. That's, hold on, I might,
Barbara
Yeah, go
Swoyer.
ahead.
Yeah. Hi. I know some of you on the call. I just wanted to chime in, and I do know Amy through social media. We are another family who receives continuous skilled nursing hours as well as PCA hours. I have been under the CCM umbrella with my son for probably 17 years now. We have 52 hours a week assigned of nursing and 68 of PCA. I'm filling about 6 hours a month of my nursing.
Wow.
And I haven't had a nurse come in about 2 years, more than maybe one shift a month from a nurse who works 2 other jobs, who's been with me for 7 years or so. I'm on open case lists with at least 5 agencies. I get 0 calls. I have probably about a third of my PCA hours filled. I'm taking advantage of there's currently, since March of 2020, a PCA to home health aid flex program that was announced but not announced through CCM to the families. So I'm getting paid right now as a home health aid worker on my unused PCA hours. All of my nursing hours are also converted to PCA hours. And I can tell you I'm also on care.com, I'm on Craigslist, I'm on probably 5 different Facebook groups, babysitting boards. I cannot find a caregiver for anything. And my husband and I are taking care of our son around the clock. He's medically complex, he's fully dependent, we're both full guardians. He lives at home full time. And I have never seen a crisis such as this. And we are involved in regular talks with CCM and OLTSS. We've discussed at length the assessment process and how it's not working for families, how it can be highly subjective, how it very often feels punitive, how families are feeling defensive, like the goal seems to be, let's see where we can reduce hours and save money, versus how can we help you take care of your son or your daughter at home so they don't have to be institutionalized. We're trying to work with them to modify and improve the assessment process. We're trying to work on programs that will develop pipelines to, I don't know if you guys saw the article even in the Globe today, things like tuition reimbursement or building pipelines through high schools and colleges and vocational programs and ENT schools, we are just facing an enormous crisis as far as home care is concerned. And I think that this section of families under the CCM umbrella, which totals probably 800 or plus families, is also in and of itself a niche market. You know, a lot of these families overlap with day hubs or residential programs or whatever have you, but
Barbara, you're off voice just there. After the overlap, we lost you. No, still don't hear you. Just, it says connecting to audio, so maybe you're coming back to us. So yes, so overlap is when we stopped hearing
How's
you.
that?
Yes,
how's that?
yeah.
All right, now I don't know what I was saying after
Oh, you were
overlap.
saying about the overlap, it's a niche. But
yeah,
you
I just
overlap with
think
residential debilitation
we
and other,
do. I mean, my son lives at home. He's been home since he was 10 years old. So that's a choice that we've made. If he didn't live at home, he would have to do something with shared living or probably a nursing home. And I know that there's a staffing crisis and medical care shortage and nursing shortage across the board everywhere, day programs, hospitals. But I think sometimes the small niche market of CCM families, being less than 1,000 families, is largely overlooked when it comes to sort of these broader programs to help beef up the infrastructure of care in the state across the board. And I think we're a small but becoming more of a vocal group to sort of express our needs and express really the emergency that our children are in, because parents, you just said something with Amy in discussion of, we are indentured servants of the state. I mean, I am taking care of my son 24/7, and I don't have a nurse coming in. And like Amy's child, my son has seizures, and you really don't justify nursing hours based on seizures, even though my son might have a seizure that's 10 or 20 minutes long and need rescue meds and oxygen and suction, and I've got the pulse ox out. I'm a marketing major from Bentley. I am not a nurse, but I'm doing every single role in my house, whether it's nurse or home health aide or PCA. I am all of those things combined, and that's going on 2 years now.
Yep. And you said 62 hours a week. He was
I
approved
have 52 of nursing and 68 of PCA.
a week,
And
right?
yes, a week.
And you're getting of the nursing, so 52, that's something like times
They-
4.3.
yeah,
We're over
200
200
something a
hours a
month.
month, right?
I'm
Yeah,
filling about 10.
yeah. So first place, I thought honestly, before COVID, the promotion, the work on Facebook and whatever was really powerful for, and it was at the level of secretary. So you guys, I just want to say, getting something done, and we were supportive of that in general, but not laser focused on this area. So you're right. There is a risk of even an AMPS group like ours, right, with the different things, saying, hey, maybe we need to now focus on this for a while. I do think it's basically, just the fact, I still can't believe on the assessment piece how it's devolved. And I know my colleague Carrie Mahoney's been in this area for decades, along with me, and this makes it at a whole other level.
Yeah, you're right. And the assessment piece, I mean, for instance, we've brought things up like for my son, whose health never changes. If anything, he declines. Why do I need an assessment every 12 months? He's the same. It moves maybe 30 minutes either direction.
Right.
And I also feel lucky, but I spend hours preparing for it. Also because I don't have nursing notes, because I am the nurse and I'm not working on a tablet with an agency. So it's almost my word against theirs. I've also
Right.
recently transitioned him out of Children's to Mass General. So a lot of our provider notes are new. CCM really shouldn't be allowed to contact our providers to discuss our children without us being involved or aware, and they are known to do that. There's a lot of turnover with case management. So every case manager who's new to your case is subjective, and they may feel, hey, you need 20 hours less, and they it's not nickel and diming, but it feels like it, down
No.
to the minute. You know, how many minutes does it take you to pull up the plunger on your syringe if you're giving your son a keto meal? And that's not the way our life works. Our kids, you know, 52 hours a week, Jake could have a crisis any time of any day, 24/7. So parents are, and we sign off on, becoming the default providers in the absence of a caregiver.
Right.
And that is just, it's unacceptable, it's unsafe, it's not fair. There's so much wrong with the system, and I could go on and on of
Yeah.
what's wrong with the
So-
system, but there's a
so-
lot.
No, so thank you for joining us and sharing your story as well. It's powerful as well. And one of the things I want to throw out to the group, I think some of these things, carefully say they're probably solvable, the assessment piece and things like that. And just for what's not solvable is having enough nursing, right? And that's going to take longer. The question becomes, the experience I had when we did that story, the interview with 7 families in 1993, something like that, I can't even remember, 94 maybe, was every single family was struggling except for one with the, and that family was actually, I think, from your neck of the woods at the time, Kerry, from the East Middlesex area. And they had a neighbor who was specifically trained on the medical stuff with their son, who was became an extra family member. So it's more like a PCA support that was quasi-medical, which I realize isn't the complete solution on the medical stuff, but she was well trained to know when they would have to, go to another level. Also, the medical situation for their son might not have been as significant, right, as what other people were facing, right? So, but what struck me about that is figuring out a strategy during this crisis period that people could be trained, and couldn't be a lot of people, it would literally be like one person. You can't have someone not trained to do this. So that's in terms of the number of people available or not available. Reimbursement is obviously something, right? That's a second thing that's got to be addressed. The assessment tools got to be addressed. Anything else that you want to put on the table?
I think there's something also to be noted in the type of blocks that the nurses are employed for. Right now, they're basically being compensated as gig workers. So you get so many hours. If the kid goes in the hospital, they don't have a job. They have to go look for another place so that they can pay the rent. So that, there's no continuity in nursing. So, but this has to be perceived as a regular job that somebody can go into and support themselves and live a normal life when they're not at work. So, that's
So you're
really
thinking,
important.
so Isaac, are you saying that the nature of the position might have to be like a full-time and half-time workers, that as opposed to 6 hours here, 8 hours there, whatever, 2 hours here, correct? Is that?
Right. You can't have somebody come in for, like 3 hours, then another 3 hours, 6 days later, make it a regular job for people to go and work, especially most families really do need nursing at night. Parents need to get some sleep.
Right.
And, how are you going to get somebody to come in, for a few hours at
So
night?
that's
once in a while?
the fourth area that I would call that model shaping, right? So figuring out, and you're going to have to compromise on that. So model shaping, so people that have a lot of hours, right? What is the best strategy for that? Because they're not going to want to completely make that the way it is because of the nature of the coverage. But but nursing entities could also have full-time people that are assigned, right, to different people as well, no?
Yeah, I want to just go back to that point about overnight. The person that came to us from Maryland was in the Maryland waiver program, where they defaulted to people in that program having overnight nursing, and then they had to justify having daytime nursing.
So when you say defaulted, because they weren't able to get help, they were able to qualify and not duplicate the state plan services. I'm just, again, we're getting into
The state plan services under the Maryland waiver program provided for nursing overnight.
Gotcha. Okay.
That was the standard. And then if you needed to have nursing during the day, you had to appeal for additional nursing hours during the day.
Okay, so you know what it sounds like offline, and we'll be happy to figure out, carve out some time to do this with you, is to connect with you on some of these things. And also help, I don't know if you need any help in terms of the leadership, over there, but clearly the things that you're sharing today's beyond just recruiting nurses. It's become similar to PCA and the other services. It's and again, a little bit surprising. I won't use the word shocking. Nothing's shocking anymore, but surprising because of the nature of the service.
Yeah.
So
We appreciate
yeah.
all the help, everybody's help. We
Do
need it.
Anybody want to ask anything else before we are at past the cutoff time, but anybody want to, this is, I'm really glad we got this all on tape, recorded, and Carrie and Kathleen, we got to figure out a way to maybe take pieces out of this too and turn them into short bits to help.
I mean, kids' safety is so much at risk given this situation, and not to say the parent exhaustion,
Right. And this is something other
Unacceptable.
groups care about. Rania Kelly's on today, and Mass Families cares about this, and other groups care about it. So it's not, you're not alone. And I'm sure it felt like you were alone for a while, and in this crazy crisis. But
Well, it's unacceptable and it's also unsustainable,
yes,
quite
yeah,
frankly.
right. And that example, you guys are doing yeoman's work, but it's not fair. And again, the guy that said that, I just want to say that Ron Preston, who's under, of all people, Governor Mitt Romney, who, by the way, of all governors, approved the AFC program for related families. Okay, talk about surprises, right? So until that day, you could not, as a family, be a home care provided through the adult foster, what we call family care, but it's also foster care program. So, and he said, we're not in Rome, Leo, ancient Rome, where we indenture people. And in fact, and that was his point, was trying, and he had been a former regional director for the federal, what's called CMS now, Center for Medicare and Medicaid. But he got it, and he had been a former aide to Senator Jeffords of Vermont. But, and I do think Mary Lou Sutters gets it. I do think we need to be louder, and it's a lot of that return taxes that had to go back, would have given a nice hand here for this program as well. So thank you for, being with us, Jake and Isaac, Amy and Barbara, and all of you that are, some of your regulars here. Appreciate you coming on and hearing about this. You obviously care, about what's happening out there. And I just want to say we'll follow up with you, and I'd love the case studies. And again, we're going to figure out a way to get cuts out of this, as well as our other ones that we've had. Next week, I think we're going to probably do more a wrap up of the last 5 weeks and look at where we are in terms of this crisis. And for those of you that care about self-determination and the Real Lives Bill, which offers more flexibility in funds, not super related to this topic, but the hearing is Monday on these regulations that are unfortunately short of reflecting the law that's in place. So we're working with folks on that, and the Mass 21 Coalition on that. And we're hoping other organizations will speak up on that. So everybody, thank you for being with us this week. Look forward to seeing some of you next week, and have a great week.
Thank you so
Thank
much.
you.
Thank you.
Take care.
Yeah.
Wow, Carrie, huh? Wow. Unbelievable. Huh. Hey, Ed, thank you, by the way. You're still there.
Yeah,